Good morning or afternoon, depending upon where you are located. And thank you for joining us today. We're going to give everyone just another moment to get settled into the meeting before we get started. Okay, while people are still joining the meeting, I'll go over a couple of logistics. If you have a question during the presentation, please drop it into the chat and we will make sure to leave time at the end for question and answers. We will also send out the deck and the recording after the meeting for everyone to enjoy. Just give everybody another minute here. Okay, thank you for joining us today and learning more about Curis and our work with revenue cycle management. My name is Haley Taylor, and I've been with Curis for about a year and have been consulting for more than 25 years in hospital systems, health centers, and corporations. Curis was originally founded as a population health consulting firm, and over time, we've expanded our extensive consulting services to include remote clinical services support as well as AI technologies. We've partnered with FQHCs, PCAs, HCCNs in more than 40 states. Today, we want to walk you through guidance around RCM, and presenting today is Kelly Duncan. Kelly?
Well, good morning, everybody. Thank you so much for joining. My name is Kelly Duncan, and I have been with Curis almost 2 years. I've been in healthcare management for 18, and over the last 10 years has been exclusively working in FQHCs. So I have held several different executive roles, from Senior Director of Operations to COO, and most recently, before joining Curis, I was a CEO for a rural health center in Montana. And during my time in operations, which is why I've decided to present this webinar to you all, I came to conclude that operations is integral in supporting revenue cycle management. And so this webinar today is going to talk to you about not just revenue cycle management and strategies to improve that, but how coupling with operations can make your revenue cycle even more successful. Next slide, please. So first, we're going to start with kind of an overview of looking at revenue cycle management as an enterprise process. So when we look at FQHC operations and revenue cycle management, when we couple those two things together, there are several things that can happen. One is we can improve patient access. We reduce revenue leakage, and we'll get into more about what that means later, and overall strengthen the financial stability without compromising patient care. So because operational workflows work directly with things like driving documentation quality, charge capture, and all of those things, we want to look at how we can standardize work around operations and metrics to support FQHC outcomes for revenue cycle. There are 4 key areas when we're looking at revenue cycle as an enterprise process that I want to lay out in the beginning to ensure that everyone understands kind of where we're coming from an executive enterprise process. So the first one is, the core principle is operations and revenue cycle are interdependent. When we standardize workflows, whether it's in clinical, administrative, or billing, you are directly impacting your financial performance. From a strategic perspective, it is imperative that we do this. We as FQHC serve underserved populations, and we must optimize our RCM in order to sustain those mission critical services that we provide to patients who otherwise may not receive the care that they need. From a financial perspective and financial impact, when you have well-aligned RCM operations, this enables you to reinvest back into your health center, whether it's through patient care, technology, or stabilizing your workforce. And finally, we're going to look at the model. And really, when you look at revenue cycle, you do want to have a single accountable RCM leader who has that cross-functional role and who will drive RCM by metrics. That doesn't mean you can't have more people involved in RCM, but you do want to have someone who is accountable for ensuring that all of the cross-function is happening and that people are held accountable that you are making success with your metrics. Next slide, please. There are four pillars when it comes to revenue cycle management. I'm going to go through the four pillars. They each have a primary focus and what their key outcome is. So when we're looking at how we're going to improve revenue cycle, these are the four key areas that we want to focus on. The first pillar is patient access and eligibility verification. For this pillar, the primary focus, obviously, is insurance coverage verification. How are you doing that? Sliding fee determination. How are you ensuring that your patients are being eligible and seeing if they are eligible for sliding fee discounts? And then financial counseling. Do you have someone on your team or a department that will look and help with patients if they need help beyond sliding fees, such as payment plans, things like that? Maybe they need some counseling around how they're going to pay their bills for your health center. And the key outcome for this is having accurate patient data foundation. How are you gathering the data, the demographics on your patient in the beginning, whether it's their basic demographic information or their insurance information? If you gather this correctly, it helps you reduce rejected claims. The next pillar is charge capture and coding. And I will say for FQHCs, this is probably one of the key areas that FQHCs struggle the most in, is having complete, compliant clinical documentation and accurate service coding. And the reason that this seems to be a challenge for most FQHCs is because we are asking providers to be coders in many instances. Many FQHCs don't have their own coders within their billing department. And so it's training and educating the providers on how to do the coding of their charges, and then ensuring that they have all the components of their clinical documentation should that be needed for a claim, which is either denied or potentially denied. And the key outcome for this is revenue recognition, compliance insurance, and reducing your denials, ensuring that you have accurate coding and documentation. Third is claim submission and payment posting. For claim submission, the primary focus is timely, accurate claim submission, and then efficient payment reconciliation. So are you getting your claims filed timely? And once you receive the revenue back from the insurance companies, is there a process for posting those payments efficiently? The key outcomes for this is clean claims, faster reimbursement, and reduced rework. Finally, the last pillar is denial management and accounts receivable. Being proactive in processing your denial appeals is crucial, and setting up a process for that. Looking at your aging AR and optimizing that to make sure that you don't have AR getting too old, because then you actually do have problems with claim submission and timely filing. And your cash flow management. Being able to have that cash flow come into your health center and manage that accordingly. The key outcomes for this are lower denial rates, obviously improved cash conversion, and reducing the amount of revenue that you need to write off. Next slide, please. When we look at operational excellence and how operations supports RCM, we look directly at multiple touch points. So whether it's patient access workflows, the clinical documentation standards, how we're scheduling our patients, and the checkout processes each contribute and impact to billing accuracy and collections in RCM. So there are four key areas when we're looking at operations that we want to focus on for RCM optimization. The first one is scheduling and template utilization. So health centers will want to look at how are they standardizing their scheduling and able to reduce missed appointments, which adds revenue, obviously, and ensure that you have proper visit type assignment. Consistent template use in EHR supports complete clinical documentation for accurate coding. Clinical documentation completeness. Again, this is timely, detailed documentation by clinical staff that provides the foundation for accurate coding and compliant claims. When we have incomplete notes, it delays our billing and increases our risk for denial. Many FQHCs and the FQHCs I have worked at, we monitor and manage how providers are completing their notes. If they're completing them timely within, let's say, 48 hours, 72 hours, or do you have some providers that have their notes out there for days, weeks, and months? This obviously has a direct impact on revenue and revenue cycle if you have note billing. And it increases your denial risk because the longer a provider takes to complete a note, they may miss key areas that they did in that visit that could support the coding of the CPT code and the ICD-10 codes that they put into the claim. Front-end accuracy. This is consistent eligibility verification, sliding fee determination, and patient financial counseling. Making sure that this is happening at registration or as close to registration as possible to prevent any downstream collection issues and ensure there is correct benefit interpretation. So who in your health center at the front end is verifying eligibility? How and when are patients being given sliding fee information to determine if they're eligible? And when are we connecting patients with financial counselors to ensure that they have information about how they could potentially pay their bill if they're having problems? And last but not least, and probably one of the most important, is point of service collections. So this is standardizing copay collection and checkout workflows to maximize same-day visit collections and reduce your bad debt. A high percentage of bad debt is uncollected copays. Many FQHCs that I have seen do not have standardized copay collection processes. And so most of those copays do get billed out and end up being written off to bad debt. When you could create some kind of operational process to have that happen when the patient is checking in, and it improves the satisfaction and compliance as well. Next slide, please. So there are some critical operational challenges that do impact revenue cycle. The first one is departmental silos. So we want to make sure, and many FQHCs, revenue cycle is seen as separate from everything else, when in fact, revenue cycle should be engaged with all departments. So one of the challenges we see is that everything is siloed. You have front desk, clinical, coding, and billing staff operating independently without sharing knowledge and understanding of the processes going on. And this definitely impacts upstream and downstream. There's lack of joint communication structures and perpetuates handoff failures. So you want to make sure that your departments are not operating independently, but interdependently when it comes to operations and revenue cycle. The other critical challenge that FQHCs face around this topic is staffing disruptions. We know about turnovers, vacancies, and competing workloads that prevent consistent execution of standard work. So as an FQHC, you could create all the standard work that you want, but if you're having high incident of turnovers, vacancies, or if people are taking on more work than they normally would, this is going to allow for the standardized work to fall to the wayside. New staff too, when you're bringing on new staff and training new staff, often don't get the training on the critical RCM tasks that are important. Those tend to take a back seat. And so staffing disruptions can definitely have an impact on revenue cycle. Medicaid churn. This is high rates of Medicaid coverage gaps among our FQHC demographic. So you have patients who may lose their Medicaid because maybe they didn't complete the proper paperwork, or they have a gap in their Medicaid coverage because they didn't provide information. How are we at the health center level assisting those patients for continuous re-verification to ensure that we don't have those coverage losses during the year? And then payer complexity, evolving payer policies, particularly around prior authorization requirements, complying with billing mandates, not knowing where we are with payer needs increases billing errors. Staff struggle to stay current with formal training infrastructure. So just in and of itself, the payers changing their billing practices and the staff not knowing what's happening will increase the challenge of having revenue cycle processes. Next slide, please. So I want to talk about some front-end optimization, particularly around patient access and eligibility, that FQHCs can implement to strengthen not only front-end operations, but then also the foundation of your revenue cycle performance. So there are several, and I'm going to go through these. I won't read each one word for word, but I will give you the gist of each one. And again, you will get the slide deck so you can see more specifically what it says. But in general, there are several process elements at the front end that FQHCs will want to ensure that they have processes for. The first one is real-time eligibility verification. Some of us may know this as RTE. And many of your EHRs have real-time eligibility verification abilities. So this is an automated process. It should be an automated process. It's the best practice to check multiple payer databases at the registration point. This is pre-employment verification when possible. So this is basically running your schedule, let's say 3 days ahead, then 2 days ahead, then maybe 1 day ahead, through this RTE verification and ensuring that patients have the insurance that is currently on file for them. And then if it comes out that the patient is ineligible for that particular insurance, now your front desk knows that they need to ask for updated insurance information. Again, the impact is reduced claim rejection and fewer payment delays. Sliding fee scale determination. It's imperative that an FQHC have a standardized documented process for all uninsured and underinsured patients to go through to see if they are eligible for sliding fee. I've seen this work at the front desk, having the patients come up, having the front desk staff go over the sliding fee scale with them and fill out the application. I've also seen some FQHCs have separate staff, such as enrollment specialists or navigators to help patients determine if they are eligible for sliding fee. This improves collections, allows you to provide transparent pricing, and reduces patient dissatisfaction around RCM. Prior authorization workflows. For those FQHCs that have maybe some specialty services or services that might need prior authorization, it's important to have identified those services requiring pre-approval and having specific prior authorization workflows. This prevents claim denials for non-authorized services and faster claim processing. Again, that patient financial counseling, having trained staff, whether that is the front desk, but most likely probably enrollment specialists or maybe some staff in your billing department, trained to explain what out-of-pocket costs may be and provide payment options that will help the patient. It increases patient engagement, higher on-time payments, and again, reduces that bad debt write-off. And finally, digital payment options. There are now multiple ways that patients are able to pay bills, either through your EHR or through other outsourced channels. That could be online, mobile, in person. So ensuring that you have multiple options for patients who want to pay their bills. And having flexible payment plans allows patients to pay those bills appropriately. We've seen a 25% increase on-time payments when you have multiple avenues for patients to pay their bills. Next slide, please. Now we're going to talk a little bit about what we call mid-revenue cycle, and this is specifically around the clinical documentation and charge capture. So we look at mid-revenue cycle as the bridge between the patient service delivery and the claim submission. So accurate, timely documentation by clinicians ensures all services are properly captured, coded, and billed. When you have incomplete or delayed documentation, this disrupts the entire cycle. Organizations that implement some kind of clinical documentation program, process, policy, tend to experience a 15% reduction in claim denials. So it's to your benefit to have some kind of clinical documentation process, plan, training in place for your providers. When we look at clinical documentation standards, from an operational perspective, it's imperative to have standardized templates and required fields. Many FQHCs will allow providers to document as they see fit, whatever they're comfortable using, and that's totally fine. But it is important that FQHCs have some kind of standardized template or at least required fields that are necessary to be part of the clinical note and documentation that we know may be required to support what the provider is saying that they provided as a service. Also ensuring that you do quality audits of the documentation, that you ensure you're managing that the documentation is timely, and training staff to emphasize why coding matters. That's very important. Charge capture systems. Depending on your EHR, do you have an integrated charge entry process capture system for immediate delivery of those charges? Workflow automation prevents mischarges and reduced manual data entry errors. So there are some EHRs, I'm familiar mostly with Epic, where you put in the charge and it immediately goes through a process of verification and then is sent off to the clearinghouse or the insurance for payment. Some FQHCs I know do still do some manual data entry. If you're still doing some manual data entry, you may want to look into your EHR and see if there are automated opportunities to reduce the errors. Coding accuracy. Again, this is ongoing staff education and periodic audits to help either your coders, if you employ coders, or your providers, if you're asking them to code, to look at diagnostic and procedure codes. There's also AI-assisted coding tools out there now that are very popular, and they do integrate with most EHRs, and that will help with undercoding and overcoding, and any compliance risks you may have with the overcoding issues. And then documentation audits. Are you doing regular review of clinical notes for completeness and compliance? Who is doing that? Is it your CMO? Do you have medical directors? Peer review for those kinds of things. Who is reviewing it to make sure they're complete and compliant? Giving feedback to staff to ensure continuous improvement, and that continues to reduce denials related to insufficient documentation. Next slide, please. From a claims management and payment posting perspective, we want to look at automation and efficiency. Claims submission and payment posting represent that downstream of the revenue cycle. These are critical processes that convert documented services into your cash flow. So it's very important to have those processes automated and efficient. So there are four specific ones that we look at from claims and payment process. The first one is claims submission. The current challenge with claims submission is, again, those who may be still doing it as a manual process. Those are high error rates and delayed submissions. Obviously, the recommended solution is automating those, scrubbing those through batch transmission and EDI integration. The outcome will obviously be higher clean claim rate and faster payment. Claim status tracking. The current challenge is limited visibility into claim status. How are we tracking what the claim status is of the claims that we have submitted? There are automated checking tools, usually within your EHR, that you can use, real-time payer feeds, and you have workflows if you need to escalate things to the insurance companies to find out what is happening with those claims that have not yet been paid. The outcome is reduced days in AR and faster payment identification. Payment posting and reconciliation. Again, the current challenge is, again, manual posting. Is your RCM group manually posting payments, or are they automated? Do they come in and do they get automatically posted to the patient charges? Also, there's reconciliation delays and unidentified payment issues. Again, recommended solution is automated payment posting if you have that available. And setting up various alerts in your EHR or the system that you use for billing to alert you if there are issues with payment posting. That outcome is faster cash recognition and you improve your AR accuracy. Finally, underpayment management. The current challenge is limited visibility into underpayment and low appeals rates. Usually appeals happen when a claim is fully denied, but there have been instances where claims have been underpaid or they've been paid incorrectly. So do you have a process for managing those types of payments? The recommended solution is documented appeal workflows around these and identifying underpayments specifically as you're going through the payment posting. That outcome is recovery of revenue that you're entitled to and improved payer negotiations. Next slide, please. Now I want to talk a little bit about denial prevention and management, being proactive versus reactive. I would say in the FQHCs that I have worked with or been in, when we get to this stage, denials, this is where many FQHCs falter. Because there are no specific operational processes about how you process denials. There could be staff that aren't trained on how to process and follow up on denials. So this could be a very difficult part of RCM. And so I want to go through how you can be proactive and not just waiting for your denials to come through. And how do you eliminate the root causes of what's causing the denials so you don't have so many denials to work through? So the first thing is to identify your top denial categories. Why are your claims getting denied? Is it untimely filing? Is it because you are coding inaccurately? Is it because there's no support from the clinical documentation? Coding errors? Are you submitting duplicate claims and so you're getting claims denied? Medical necessity issues, etc. So you want to find out what are your top denial categories and hone in on those specifically. Prevention strategies. Once you determine what your category of denials are, now you want to figure out how can we prevent these? Is it because we don't do insurance verification up front? Do we not have those standardized documentation templates? Do we not have automated prior authorization workflows? So once you determine the denial reason, now you want to look at how you can prevent that. Denial tracking and analysis. This is another area where FQHCs falter in RCM, is not tracking and analyzing the denial. So once an RCM biller may work the denial, they may not look at it again for a month, 2 months, 3 months. So how are you tracking those? It's imperative to have some kind of weekly denial log categorized by reason, and following up on those appropriately to ensure that not too much time lags between when you submitted the denial for an appeal and when you're following up on it. And the appeals process. So the appeals process can be lengthy depending on the insurance company, but if the FQHC has a documented appeals procedure with clear timelines, that will help you follow up on those and keep those at the forefront. Sometimes you will need clinician involvement, especially if it was denied for a medical necessity reason. So ensuring that you're engaging the provider when necessary. And if the appeal becomes too onerous, you may need to escalate that to a revenue cycle director or someone else who can help with those issues. But having an appeals process formally is important. And then finally, for feedback loop, having a monthly review of denial trends, looking at that from an RCM perspective and seeing if you're seeing trends that you can now determine what was the root cause of those trends and go back to process changes that will help impact those denial trends. Next slide, please. So cross-departmental communication. So we talked about RCM being interdependent with other departments. And a successful RCM requires breaking down those silos, as I mentioned before, and creating a shared understanding of revenue cycle. So here are some key strategies that you could implement in your FQHC to ensure that you are breaking down those silos and having that cross-departmental communication. The first one, and the one that I've seen is very successful, is weekly operation and RCM huddles or meetings. So this could be, and this is just a suggestion, a 30-minute standing meeting, potentially having representation from your front desk, your clinical leads, coding and billing and operations, and having an agenda-focused meeting with priority metrics, barriers, and quick wins. Document those actions with owners and due dates. So basically it's getting everyone in the same room for a specific amount of time on a weekly basis to talk about revenue cycle and how all of those different people from those different departments can help support revenue cycle, whether it's through process change, whatever the case may be, but you need to get all of the people in the room together to have those conversations. It's not just RCM having those conversations independently, it's sharing that information and coming up with solutions and action items to improve it. Role-based training program. This is front desk staff training on eligibility verification, patient communication. Do you have training programs for your front desk? Do you have training programs or training information for your clinical staff around documentation and coding? Do you have training for your billing staff to become more experts in claims processing? It's this ongoing training, not just for new staff, but for established staff, to ensure that they understand what the responsibility is on their part for that particular RCM requirement. Monthly RCM operating review. So this is facilitated usually by a revenue cycle director or manager, and it's reviewing what we call a KPI dashboard. And so this is, and we'll look at the KPI dashboard in just a minute, but setting specific targets for specific metrics and managing those on a monthly basis, not just looking at them, but creating action plans around improving them if you're not meeting your targets. So that's a very important thing to have. And like I said, we'll look at KPIs in just a minute. And then cross-functional design, process design. When you're redesigning workflows, whether it's things like charge capture, eligibility verification, ensuring that those representatives from all the affected departments are involved. So really, if you're doing any kind of cross-functional function, process design, redesigning your workflows, that would be something great to do or to talk about in that weekly ops RCM huddle so that everybody is there, can give their input from their perspective, and you could come up with a functional process that's going to work for everybody. Next slide, please. So now we are going to talk a little bit about data-driven performance, a KPI framework and targets. So at Curious, we're very data-driven, and we think that data is very important when you're looking at strategizing, continuous improvement, and the like. So these are some key data metrics from an RCM perspective that I would encourage you to start utilizing. And as far as the benchmarks, I will say that these are best practice benchmarks. And so, depending on where you're starting in your FQHC, you may not want to hit these benchmarks specifically right away, but these are probably benchmarks that you want to build up to. And so this is something that you could consider as a long-term strategy to get to these particular benchmarks. So the first category is claims quality. And this is looking at your clean claim rate or your first pass approval. So when those claims are submitted, hopefully through an automated process in your EHR, do they pass the first approval without getting rejected or pulled back because they're missing something? What is your clean claim rate? So the target benchmark, right, is greater than 95%. That would be a best practice ideal state. So that is one of the metrics that you should consider beginning to look at from an RCM perspective. All of these would be reviewed monthly in that KPI dashboard. The next one is denial performance category. So that's your denial rate, right? Simply what percentage of your claims are denied. And that, again, a target benchmark would be less than 5% of your claims being denied. Again, looking back at all of those components that can improve your denial rate. So those would be something that you would look at in conjunction with this particular metric. Again, under denial performance would be appeals success rate. So that's that appeals process that you would put in place. And what is the success rate of getting those appeals approved? You would be looking at an ideal target benchmark of greater than 75% of your appeals being successful. Of course, we're not going to have 100%, but this is something that you would want to strive for. There are two collection efficiency KPI categories. The first one is days in accounts receivable, obviously, and I'm sure most of you already have this metric. This target benchmark would set it at less than 45 days. I'm sure that your financial, either CFO or someone has determined what is best for your health center. But days in accounts receivable is one that you would definitely want to track. And then your net collection rate is another one that you would want to ensure that you are tracking. From a patient responsibility rate, this is the collections rate. This would be the copay collections, or if you wanted to expand it to be any collections. So if you have patients that owe money, and not just for copays, but just in general, right? What is your collection rate? Or you could specifically do it around copay collection. I have seen copay collection be the specific one that people track, and the greater than 80% is usually a pretty good measure. So that probably could be one that you could strive for, that 80% of your copays are collected at the time of service. Operational efficiency, average days to claim submission. So this is from the time that the service happened to the time that the claim is submitted. Ideally, it would be less than 3 days, not much more lag time than that. Again, this is looking at not just if you have an automated or manual process, but also does it depend on if your provider is signed off, completed and signed off on the note. So if your provider, again, is not doing timely documentation, this could affect this particular metric, and you could see those days increase from date of service to claim submission. And then the final one is just a first contact resolution rate. This is particularly if patients have billing questions, billing issues. Are you able to resolve those billing questions and issues at a first contact resolution? Next slide, please. From a technology perspective, this is around EHR integration and automation. So again, we've talked throughout this webinar, as much automation that is possible should be implemented if you have that ability, whether it's your eligibility verification, charge posting, claim status checking, etc. It not only frees up your staff to focus on other complex issues, but we have AI in our midst now. Lots of opportunity. And so if you have the opportunity to streamline things through automation, whether it's AI or other, and you have the ability to do that, that is an important part of the RCM process. So looking at integrating real-time data flow between clinical documentation and billing systems, again, automated eligibility verification, automation of claims being sent, that AI-assisted coding, lots of opportunity exists around AI-assisted coding now, automating those payments, and patient engagement tools, whether that's bill payment through portals, through that financial counseling opportunity, and automated patient billing notifications. So really anywhere that you can advance technology within your RCM is only going to improve your outcomes. Next slide, please. I want to focus a little bit on staffing, training, and workforce sustainability. So one of the issues that we have, particularly in revenue cycle, is high turnover. And I think we're all familiar with turnover in our FQHCs. And to sustain RCM process amid staffing challenges, again, investing in those automation tools, offering training, professional development opportunities, that allows you to retain skilled talent in those roles. So I would say that from a staffing, training, and workforce sustainability, when you bring staff into those particular roles, giving them role-based training, professional development, what are some retention strategies that you could look at? Supervision and feedback is important. And do you have contingency staffing? So if you have people who are, let's say, posting your claims, posting your payments, and they happen to be out, do you have contingency plans of other people who can keep that information flowing? So I've seen in many FQHCs, if it's, one or two people that do it, and those two people are out for an extended period of time or leave the organization, sometimes those things suffer because we don't have people who have the knowledge and the training to take those over and do those. So I think from a staffing and training perspective, it would be important to have other people who could do those key critical components of revenue cycle to ensure that it doesn't stop. So that is very important. Next slide, please. I want to talk just a minute about outsourcing. So how and when do you leverage external partners? In many FQCs I've worked in, it's been all in-house revenue cycle management, but for a few FQHCs, especially for the smaller, maybe more rural FQHCs, I have seen outsourcing. And so sometimes you need to turn to external partners to help you manage components of your revenue cycle management, and that's okay. Whether it's, you need help with denial management, or you need help with coding or claims processing or payment posting, there are opportunities to outsource some of those functions. So again, like I said, denial management, claim submission, status tracking, maybe you need some outside financial counseling services. Those are some functions you could look at. Some functions that you want to retain in-house, though, I would say if you're looking at outsourcing, is that front-end eligibility verification and the clinical document oversight. Those are two things that I would not outsource because I think they're imperative that they're kept within the FQHC for accuracy. How do you select partners? I think that you could partner with, I think looking at specifically partners that work with FQHCs and the specific FQHC billing practices. Sometimes if you're part of your state PCA, they will have people who maybe they have selected or people who they know are of high caliber and that you could share in. So, but I think making sure that they specifically know FQHC billing is important. And then having that oversight, making sure that you have regular performance reviews with those outsourcers and regular ongoing communication, and that they understand what your expectations are around RCM. And just that ongoing communication is important if you're going to outsource any of your key billing functions. Next slide, please. And again, addressing some specific FQHC RCM challenges. That Medicaid churn that I was talking about earlier, making sure that you are proactively outreaching to patients who may have experienced coverage loss. Do you have financial counselors or enrollment specialists that can help those Medicaid patients specifically to ensure that they don't lose their Medicaid coverage during the year? The sliding fee scale administration, how do you administer that? How do you develop the criteria? And how do you communicate to patients their eligibility? Safety net funding optimization. So do you have an expertise in federally qualified health center funding? How does grant funding coordinate with your RCM performance? So that's also an important component. Uninsured patient collections. So if you have uninsured patients, having flexible payment plans and that financial assistance is important. And again, that will reduce your bad debt write-offs. And resource optimization, prioritization of automated investments in high volume processes, strategic staffing and process standardization to enable small staff operations. I would say that this is very important. If you have funds, revenue to invest in to improve your RCM, starting with those automated processes is probably where I would start. If you have the ability to invest in improving your RCM, that would probably be one of the top strategies I would say to look at. Next slide, please. So at this end, I just want to talk a little bit about how would you implement some of these things. So, this is great information, you all could take with you, but then how do you actually go about successfully implementing integrated operations and RCM? So it does require a structured approach, definitely a phased approach to demonstrate wins. So you don't want to take everything and say, okay, we need to do everything in the next 1 to 2 months. I would say that, and look at this in just a minute, the roadmap should address quick wins in 1 to 3 months, let's say. So let's say you say, okay, in 1 to 3 months, we want to ensure that we have a robust eligibility verification process and a charge capture process. And then maybe to develop the foundation in months 4 to 6, you look at a metrics infrastructure, how you're going to measure your KPIs. A training rollout either for clinical documentation or front-end operations. And then for sustained improvement, that's where you're looking at kind of the 7 to 12 month time frame. This is continuous process refinement and that technology optimization. So if you were to look at kind of a timeline, right, this could be over the next, let's say 12 months, some key areas that you focus on, doing the quick wins first, the foundation, and then the sustained improvement. Obviously, for a lot of these, you need executive buy-in and sponsorship. You need clear accountability ownership in order to overcome any competing priorities or strategic objectives that may be counter to some of the things that you would want to implement. Next slide, please. And this is just a layout kind of a 5-step of how you could design this. So the first thing would be to assign a single accountable leader who is going to oversee this and be accountable for implementing and integrating these changes? How do you define that cross-functional roles and responsibilities? How are you bringing people together and breaking down the silos within your organization between operations and RCM? Third would be adopting a set of KPIs and setting your targets. So, starting with some of those basic metrics, determining where you currently are, and maybe in a phased approach in the next 6 months, where do you want to get to? And then in the next 6 months, where do you want to get to? Hopefully striving for those target benchmarks that would be ideal that we saw in a few slides previously. For conducting that process mapping of current state, right? So where are you current state and where do you want to be? And then identifying the quick wins. Where can you make where's some low-hanging fruit that you can do quick wins of things like eligibility verification, charge capture, etc. And then it just goes down kind of re-emphasizing what we already talked about, but this is laid out in more of a strategic way of how you could implement these things. And then at the very end is the measure of impact and how all of this coming together is going to impact these specific RCM targeted outcomes that will improve over time. And next slide, please. I believe this is our final slide. So out of all of this conversation, what are the expected financial and operational outcomes that you are looking for? Of course, denial rate reduction, right? You want to reduce your denial rate of your claims. That's very important. How do you accelerate your cash flow? So it should accelerate your cash flow. Days in accounts receivable would be less, and through standardized processes and automation, you would advance that cash flow. Revenue recovery, implementation of clinical documentation will yield more revenue recovery, and charge capture optimization will reduce that revenue leakage and turn it into revenue recovery. Administrative efficiency, automation obviously will cut administrative costs and be more efficient. You'll have cleaner data and processes which reduce rework. Patient experience, when you have transparent pricing, you have accurate financial counseling, and those multiple payment options, you increase patient satisfaction and compliance. And last but not least, overall, it helps you sustain your mission. When you improve your financial stability, it allows you to sustain and expand access to those populations that we serve, reinvest back into your FQHC, and create more stability and have that technology modernization also. Next slide, please.
Thank you, Kelly. That was terrific. Now we will take some questions from the chat, and I've also placed our contact information in the chat there below. Should you have any future questions or you would like to schedule a call with our team. Are there any questions we want to address now? No, we have a couple minutes left. Also, feel free to put up your hand and we can unmute you. Okay. Well, thank you for your participation and your commitment to strengthening your organization's revenue cycle performance. As Kelly discussed, it is important to remember that a strong revenue cycle is more than a billing function. It is a strategic driver of financial stability, patient access, and organizational sustainability. Every step of the revenue cycle, like she discussed, from patient registration all the way to collections, contributes to the overall health of the organization. We encourage you to take all of the strategies that she discussed today back to your teams, identify a couple opportunities for immediate improvement, and then continue your work towards a more efficient, effective, and sustainable revenue cycle operation. Ultimately, organizations that invest in strong revenue cycle performances position themselves to better serve their patients, support their workforce, and sustain their mission. Thank you again for joining us. We look forward to seeing you soon. Thank you. Thank you, Krista. Thank you for the feedback. Appreciate it. Y'all take care. We will see you again at our future webinars.